So good evening again. I'm Seymour Williams, the team lead for the Workforce Institute Development Branch Field Epidemiology Training Program. And it's my pleasure to welcome you to the poster session for the FETP TEPHINET International Night event. So as you come into the room, try to move over to this side. You can bring your food with you. My job is very simple today, and yours will be too. You've shown up because we have quite a cast of international FETP residents who will be presenting their posters, oral posters, and we'll get some more details of how that will be done. Before I do that, it's my job to introduce the moderators for the session. So I'll take a few minutes to do that, but I'll let. So we have approximately 18 posters, and we have judges, and we have moderators, and you'll get a chance to hear and ask really probing questions to ascertain, the depth and the knowledge and the quality. But the biggest impact is that this represents work that we're supporting internationally. And we're building the workforce to support public health in these countries, and it's quite a privilege to collaborate in this way. So the moderators for tonight are two persons that I've had a chance to work with, and it's a pleasure. The first moderator is Reina Tercios-Ruiz. She's a medical epidemiologist and infectious disease specialist. Since middle of 2017, Dr. Ruiz has led the monitoring and evaluation team in the Workforce and Institute Development Branch in the Division of Global Health Protection. She has conducted extensive international work over her 16 years with CDC. She started her career as a National Foundation for Infectious Disease Emerging Infectious Disease Fellow in 2000, and in the following year, Dr. Ruiz became an Epidemic Intelligence Service Officer. Dr. Tercios-Ruiz was the resident advisor for the Central America Field Epidemiology Training Program based in Guatemala from 2011 to 2015, supporting the training of over 500 residents in field epidemiology in 7 countries. She then served as the director of the CDC Central America Region Office in Guatemala until the end of her term in Central America. Dr. Ruiz attended medical school at the Universidad Nacional Autónoma de Honduras and completed her internal medicine residency in Mount Sinai in Cleveland, Ohio. We'll save the clap for later because they have work to do. Dr. Mufuta Shimanga is a professor of public health medicine at the University of Zimbabwe. Since 1997, he has served as the director of the Zimbabwe FETP, a joint program of the Ministry of Health and the University of Zimbabwe. Professor Shimanga has developed expertise in FETP implementation, intervention study designs, and has a reputation for scale-up in resource-constrained setting. He leads one of the institutionalized and first set-up FETP programs in Africa. Dr. Shimanga has published over 100 papers in peer-reviewed journals and is a founding member of both TEPHINET and AFINET. We thank you, Dr. Tercios-Ruiz and Dr. Shimanga, for stepping up to do this role. So Bob, Dr. Bob Fontaine is next up to explain the poster session, and then we'll progress rapidly through this. Pay attention to time. Time is very important. You get something to eat, but we're going to move through this very swiftly. Bob.
So we've gone through a lot of posters, a lot of abstracts in the past several months, and gone through a few procedures to winnow them down. I still don't know if we absolutely have all of the best ones in here, but we've done our best, and I've seen all of the poster presentations already in a trial and the orals, and I think they're all worth seeing. There's a lot of varied topics, and they're well presented, and they're on time, most of all. Okay. So now, this is called a poster session, but I was reminded by a colleague of mine that these aren't really posters anymore. These are orals. We could call them mini orals. They've changed over the past several years. And each year we've gotten a little bit better at improving the audibility, the understanding of the posters. In the past, there was too much background noise, and then people couldn't get close enough to the poster. So now we've ended up with a screen like this. So we have a mini oral. So, and the only real complaint I had about it was some of the residents said, "Oh, we have to come and do an oral?" And that's a lot more work. And you bet it is, but you get some good visibility with it. And the other thing I want to say is that in looking at everything, it's a very difficult choice between making something an oral or a poster in all of this. Most of the posters could easily have come up as orals. So our selection isn't perfect, and it's never going to be. So I think that you should all be proud of being in the poster session for International Night. Just a few things about movement and housekeeping here. And I don't know if I have them all. I might even ask Claire to tell me something. The poster session will be broken up into two rooms. One is straight through that little door back there, the back door, as they say in computer tech language, and into room C. This is room B. There's a schedule for each one, but the schedule has changed slightly, and I thought we would have them. Claire, where are the posters that say which is in each room?
Posters, we don't have a poster.
Okay.
They're aware of which room they're supposed to be in. If you want to real quick.
Okay. Okay. Well, so so we don't have it posted then, right? Okay. Okay. So you'll have to look at some of the schedules. I can read it off here now. In Group 1, Room B, we have an outbreak of gastrointestinal disease associated with Bacillus anthracis, probable pertussis outbreak in unvaccinated population in 3 hard-to-reach satellite communities, risk factors associated with cervical dysplasia among women living with HIV, cost-effectiveness analysis of SMS messaging and home visit reminders in reducing missed childhood immunization clinic appointments, an outbreak of culture-confirmed Candida auris bloodstream infection in a neonatal unit in a public sector hospital in South Africa, transmission of Neisseria meningitidis at a military training unit in Vietnam, adding methanol to rice wine is a risky practice in an outbreak in Cambodia, and prevalence and determinants of delay in seeking medical care among newly diagnosed pulmonary tuberculosis patients in Kyrgyzstan. So that's room B here. And in room C, through the other side, leading off with an outbreak investigation of brucellosis at a semen production unit in Pakistan, smoking prevalence awareness and tobacco cessation training among healthcare professionals in Cameroon, presentation of herpes simplex virus type 1 in pediatric burn patients in a hospital in South Africa, outbreak investigation of anthrax in Silkoi village in India, investigation of a measles outbreak in Afghanistan, communicating prevention messages in the digital age using dating applications and mobile websites to reach men who have sex with men during an outbreak of hepatitis A, acute diarrheal disease outbreak due to cross-contamination of bore wells in a tribal village, meningitis, Neisseria meningitis C, isolated from an outbreak in a prison investigation, maternal risk factors for preterm births in selected health facilities in central Kenya. So those second 9 will be over in the other room. Now, I'm sorry we don't have anything more complete than this. There was a schedule that might have been handed out earlier, but a couple of the titles have changed. One was moved in time, and another one was moved from one room to the other. So those of you who have interest in the ones that I read off in Ballroom C, you can go to the other room. And those who have interest in the ones that I read off here can stay here. And if you're not sure, you can just go back and forth through the door there. So with that, I'd like to turn this back over to Seymour.
So I guess we'll begin with our first presenter. That too. Okay.
I'm sorry?
Do you need help to
No.
find the poster?
No, it's good. Give me a moment. Okay, we're going to give a couple of minutes. Good evening. My name is Reina Tercios, as Seymour indicated. We're going to give our colleagues a couple of minutes to go to the other side if that's where they're going, and by that, I mean Ballroom C, not anywhere nefarious. Meantime, I'm going to ask Dr. Freda Loyaseng to come on up and begin to pull her presentation, and she will present on a suspected outbreak of gastroenteritis associated with Bacillus anthracis, Uganda 2019. You will have 5 to 7 minutes to present, then we will take questions, and I will take the moderator's prerogative and ask the first question, giving time for the person to come up to the microphone on this side of the room to pose their questions. There will be limited time for questions, so please think of one that will be particularly relevant.
Good evening. Anthrax is a zoonotic disease caused by Bacillus anthracis, which is a gram-positive endospore-forming rod-shaped bacterium. It is a category A agent because of its potential for bioterrorism. People get infected when spores get into the body, and there are 3 common forms. GI anthrax is caused by eating raw or undercooked meat from infected animals. Symptoms are initially non-specific, like nausea, vomiting, anorexia, diarrhea, fever, among others, progressing to severe, like abdominal pain, hematemesis, bloody diarrhea, among others. It has an incubation period, usually 1 to 6 days, and the median is 3 days. On the 24th of August 2017, Isingiro District, Uganda, reported an outbreak of acute gastrointestinal illness with dozens of cases. The symptoms included severe abdominal pain, bloody diarrhea, among others. The outbreak reportedly occurred after eating meat from a sick cow. The physician suspected GI anthrax and treated patients with IV antibiotics. There have been several human anthrax outbreaks in Uganda since 2007. We set out to investigate this outbreak, and our objectives were to determine the cause of the outbreak, to identify exposures that caused this outbreak, to recommend evidence-based control measures, and we defined a suspected case as acute onset of diarrhea or vomiting during 15th to 31st of August in a resident aged at least 2 years of Kabingo sub-county. A confirmed case was a suspected case with vomitus or stool sample yielding Bacillus anthracis by culture or PCR. To find cases, we reviewed medical records and actively searched by asking key informants. There were 61 cases, and noticed that there were no deaths. Males and females were equally affected. The attack rate increased with age. There was fewer bloody diarrhea than expected with GI anthrax. The epi curve indicated a point source outbreak. Notice that GI anthrax has an incubation period of 1 to 6 days with a median of 3 days. The sick cow was sold to Butcher X, who butchered and sold the meat on the 17th of August. The primary case occurred a day later. The peak occurred 3 days later. The last case occurred 7 days later. Therefore, this epi curve is consistent with a point source GI anthrax outbreak. We conducted a case control study using 50 cases and 100 controls. The controls were asymptomatic villagers, frequency matched by village of residence. Eating beef during past 2 weeks before the outbreak was strongly associated with the disease, with an odds ratio of 7.1. Among those who ate beef, eating beef from Butchery X was strongly associated with disease, with an odds ratio of 327. Among those who ate beef, eating boiled beef only was protective against disease onset, with an odds ratio of 0.099. That is a common method of grilling meat in Uganda, where it is cooked on open fire and it is often still raw inside. Butchery X sold 2 kinds of beef. The cheap beef was sold at half the normal price and was often from an unknown source. Microscopy of cultured vomiters showed gram-positive rods with endospores. PCR and sequencing found that the Bacillus anthracis strain was missing the PX02 plasmid, which indicated the stand strain. The stand strain has the PX01 plasmid and lacks the PX02 plasmid. It is the predominant strain used for livestock vaccination. There have been no reported human disease linked to the stand strain. The suspected beef was from a sick Frisian cow of unknown origin. The government never conducted mass vaccination in the district, although the vaccine is available privately. And normally it's those that have special breeds of cattle that do the special vaccinations. They feel they're taking special care of the animals, so they go the extra mile and do certain things like the vaccinations. Our limitations included limited information on the implicated cow. It wasn't tested to confirm the cause of death, and the vaccination history was unknown. Cross-contamination cannot be ruled out. Clinical samples were manipulated before culture or PCR was conducted. Other common diarrhea illnesses were not investigated. We concluded that this might be the first time the stand strain was isolated from a clinical sample of patients with GI symptoms. Epi and lab evidence suggested stand strain might be associated with the outbreak. For our public health actions, we closed Butchery X and did community health education, where we advised them to properly dispose of carcasses of animals that died of unknown cause, to avoid eating meat from animals whose cause of death was unknown, avoid eating unusually cheap meat, and thoroughly boil meat before eating. We recommended routine inspection of commercially sold meat, improving national surveillance for anthrax in both humans and animals, and improving record keeping of livestock vaccination and health. I would like to acknowledge the following. Thank you.
Thank you so much. While some folks get to the podium, to the microphone for questions, I think I'll start with the first one. Congratulations, that was very nicely done.
Thank you.
And talk about something that's as effective as having removed the handle of the pump. Very true in the snow tradition. So I would like you to address the choice of the referent group when you calculated your odds ratio. I believe you said that the reference group was the folks who ate grilled meat, and that was compared with folks who ate grilled and boiled versus the ones who used boiled and grilled. We tend to think of going to an extreme, either the one that has the most likelihood of conferring infection or disease. Can you talk a little bit about that, since the grilled meat was often raw?
Okay, based on the analysis that we took, we decided to, it was actually a point of discussion. We decided to use those that ate the grilled meat as the reference group because we wanted to look at it from the positive side and tell the people that, you know what, boiling beef is protective instead of coming from the angle of grilling only will make you sick. That was why we chose to use the other way around, so that we could give them the protective side of it. Yes.
Thank you for an interesting presentation. I definitely have I have an interest in anthrax. But so I had a question. So you said that the attack rate I think was larger, higher in older people. Were you able to look at are older people, older age groups more likely to eat grilled meat versus boiled meat?
I beg your pardon?
So I think you showed that older individuals had a higher attack rate. Is that correct?
Yes.
Were you able to look at, do older individuals, are they more likely to eat grilled meat only versus boiled meat? So
Well, thank you for your question. Well, what we know is from the culture, the older people normally are the ones that go out and buy meat from the trading centers. It's really unlikely to find children buying the kind of meat that I showed you before. So we know that that is the reason that the attack rate was highest in the 50-plus age group.
thank you.
Welcome.
Thank you. My name is Andy Mitch. I'm a CDC epidemiologist. Thank you for all that. Those sound like some compelling public health actions, including the messaging, and I was wondering if you can comment on how you would get the word out and also the likelihood of getting traction on those messages. Cooking, avoiding dubious sources, and so forth.
In Uganda, we have village health teams who are a group of people that actually go out into the communities and sensitize the population. So what makes it effective is the fact that the health system is broken down to the grassroots level. So we talked to these people and gave them the recommendations that we had and sensitized them based on the public health actions. We educated them, and they were able to transfer this information to the communities. So we believe that that made a difference.
I think we're at time. Thank you so much. Congratulations. Our next presenter will be Dr. Joseph Efa, and I am so sorry, Achempong, probable pertussis outbreak among unvaccinated populations in 3 hard-to-reach satellite communities in Pru District, Ghana, 2017. You can start pulling your presentation.
Good evening. My name is Joseph, and I'm presenting on probable pertussis outbreak among unvaccinated population in 3 hard-to-reach satellite communities in the Pru District, Ghana. Now, pertussis is a vaccine-preventable respiratory disease caused by Bordetella pertussis. Signs and symptoms include watery eyes, rapid cough, whoop sound, and fever. Pertussis vaccine is a component of the pentavalent vaccine given in 3 doses during infancy. It's given at 6, 10, and then 14 weeks. Now, on the 30th of October 2017, a cluster of suspected pertussis cases was reported in the Pru District. The cluster were in 3 hard-to-reach satellite communities, Brenteke, Driver-Akura, and then Wotsidike. We sought to investigate to confirm the outbreak, to determine its magnitude, and also to implement control measures. The study was a descriptive one from 30th October to 21st November 2017. The outbreak location was Pru District in the Brong-Ahafo region, and specifically the 3 hard-to-reach satellite campus, hard-to-reach communities. Now, on the map of Ghana, you see the Pro district being highlighted with Yeji being the district capital of the district where the 3 hard-to-reach satellite communities are found. Now, we used a case definition of first, a suspected case as any resident of Pro with cough illness, any of the following paroxysms of coughing, inspiratory woof, pertussive vomiting, or apnea from 1st of October to 27th of November 2017. A probable case was defined as a suspect that shows gram-negative cocobacilli in a throat swab. Confirmed case was the isolation of B. pertussis after culture has been done. So you could see in the figure there that the investigator is paddling to go to the community, which is very difficult for you to go by. Now, data was collected through review of medical records. Active case search was also done. Sampling collection was done through tool swabs for investigation. Data analysis was done with EpiInfo using frequencies and proportions to describe how the analysis was done. And tables and figures were the main mode of data presentation. Now, overall, there were 1,742 residents with 72 suspected cases and no death. The median age was 9 years with range from 0 to 65. Now, the males had a higher attack rate of 2 against their females who had 1.1%. Now, the overall attack rate was 1.5%. And then the epicurve was more of a common source. Driver Akura and then Brentike share the same health facility. So on the 9th of October, they went to the health facility, and afterwards, on the 21st of October, the first case was developed. And afterwards, the first case was developed in Driver Akura. Afterwards, subsequent cases continued to develop in that community. Now, Utideke also had a cluster of cases in a compound house where most of the cases came out. Now, the index case had also attended hospital in Driver Akura as well, and hence it makes it a point source where it came to in contact with the pertussis case. Now, 42% of Driver Akura was the attack rate. 0.9 attack rate was for Wutidike and 0.4 for Berentike. 27 cases overall and 85 contacts. Now, 6 out of 27 cases were admitted for severe disease. The vaccination status of the whole satellite communities were 15%, which is very low. And also the vaccination status for the whole Pro district is also very, very low, as it was 74%. 9 out of 13 specimens were positive for gram stain. Isolation was not done because we don't have the capacity to do isolation in Ghana, and there were no transport media to also transport the samples to the laboratory for it to be done. So this is a heat map which explains where the hospital is and also the various satellite communities. Now, we also did a laboratory results of pertussis, and the males had a PVP of 71.4 and also a total PVP of 69.2%. Environmental assessment was also done as part of the outbreak investigation, and averagely 7.7 people were living in a room, which also signifies an overcrowding status in the communities, and rooms had an average of 1 window. Now, in conclusion, we said there was an outbreak of pertussis in the Pro district affecting mostly children and less than 3 years, and the pentavalent vaccine coverage was very low in the Pro district. We did case management, contact tracing, and timely mop-up of vaccination campaigns were the control measures that we did, because we gave out the pentavalent vaccines to the children who had not received it. Also, we did PEP distribution of azithromycin in the communities. Poor ventilation and overcrowding were also some of the things that we concluded on. Now, with our recommendations, Pro district should be improved enough to have a standard vaccination coverage. Also, we also recommended that the National Public Health Lab should be resourced enough in order to be able to test for Bordetella pertussis locally, the isolation. Now, with our public health action, we did a mop-up vaccination campaign, and we distributed post-exposure prophylaxis to the communities. We also did community and school educations as well on proper etiquette of sneezing and coughing, and also the need for mothers to take their children to the various health centers for them to complete their vaccination status. So with acknowledgement, we acknowledge these people. Thank you.
Very nicely done. While we get questions coming up here, we're going to go ahead and ask one for you to clarify. Did you say that the 3 clinics shared something? They shared staff? They shared what?
The 3 communities share a clinic, a health center.
So folks from the 3 clinics will come, from the 3 communities will come to the same clinic?
Yeah.
Okay. And then the question I had is that there has been a lot of discussion about case definition for pertussis based on age, because pertussis doesn't behave the same in younger children than in older children. Would you clarify a little bit on that, and also talk about why you saw, or what do you think is contributing to that disparity between males and females?
Okay, so the case definition that we used was basically for children, because most of the cases that we found when we went there was basically associated with children. Now, the disparity that we also find concerning the male and the female was that most of the male children tend to go to these health facilities more than the females. And also, the study also found out that there are a lot of males whose parents reported them more to the health facilities. But there wasn't any special relationship as to why the males were high or the females had the lowest attack rate.
Thank you, Joseph. Peter from Gambia and Liberia, FETP. I'm just curious about the heat map.
Okay.
I want to know why you used the heat map. And also I want to ask whether you considered about finding out the source of this outbreak. Thank you.
Thank you. Okay, so basically the heat map was used to describe how the cases are in the various communities, and also it also helps us to know how the communities are separated from each other, and also to describe the health facility where it is positioned in the communities. Yeah, and also with the source, we tried finding out where the source was coming from, but it was difficult for us to be specific on a particular source when we went to the health facility, because they didn't really give us a clear indication of the person who came there first and exhibited these signs and symptoms there. So that's the reason why we weren't able to really find the actual person who exhibited the case at the health facility the said date.
Hi, thank you, and congratulations on a nice investigation. One of your immediate actions was a vaccination campaign, which is great to address what seems to be like a very severely under-vaccinated community, if I understood right. 15%, was that? Yeah,
that was, when we did the study, only 15% of the people who had the pertussis are vaccinated.
Right. Yeah. So one of your recommendations here was that the district should improve vaccination coverage. I'm wondering if you could say a little bit more about that and talk about what the barriers to vaccination seem to be in these communities, and more specifically, what steps can be taken to, I mean, the mop-up campaign is great, but I think a longer-term solution needs to be strengthening the routine immunization, it sounds like.
Okay. So because these communities are hard to reach communities, you need to paddle, you need to move on a river before you go to the various communities. The health professionals tend not to go to these areas. So it's more like if a mother is able to come to the main district, which is Pru, then the mother will be able to take the child to the hospital for the child to receive the vaccine. But apart from that, the district health doesn't move to these communities because it's very difficult to go there, and they find it very stressful to go to these places. So we recommended that these places are very low when it comes to vaccination, and it's important that they try to extend the coverage of the vaccination in these areas.
Well done.
Okay.
Thank you. Our next presenter will talk about risk factors associated with cervical dysplasia among women living with HIV, experience from a low-resource setting, Gambia.
Good evening. Cervical dysplasia and associated risk factors among HIV-infected women attending hands-on care center, Brikama, the Gambia, 2017. The background of the study. Cervical dysplasia is a precursor of cervical cancer and is found to be higher in women living with HIV. In Africa, and particularly in the Gambia, there is very little precise data on cancer due to limited cancer registries in the country. Therefore, data on cancer is always used from the developing countries. This deprived programs of evidence for decision-making. We assess factors associated with cervical dysplasia among HIV-infected women at Hands-On Care ART Center, Brikama, Gambia. The objectives of the study were to determine the proportion of cervical dysplasia in HIV-infected women, and specifically to determine the socio-demographic, reproductive, behavioral, and clinical risk factors associated with cervical dysplasia in HIV-infected women. The study area was the Brikama district in the Gambia. We used a cross-sectional survey among ART clinic attendants at the Brikama Hands-On Care Medical Center from February to May 2017. We did a systematic random sampling with a sampling frame of 1,440 and minimum sample size of 322, getting a sampling interval of 4. We obtained data with a pre-tested semi-structured questionnaire to abstract social, demographic, behavioral, and reproductive data, and we obtained clinical data from hospital records. After this, we did a visual inspection with acetic acid, screening for acetowhite lesions. Patients with dysplastic lesions had cryotherapy done for them and were referred for 3-month clinical assessment and re-screening. We analyzed data descriptively and analytically. We used chi-square measures to test the significance of VIA positive and categorical variables, and we did the logistic regression to measure the risk factors associated with cervical dysplasia. This is the key investigator doing the VIA. Now the results. A total of 322 women were screened and all were on antiretroviral therapy with mean age of 35 years plus or minus 8 standard deviation. Proportion of cervical dysplasia among these women was 22%, and all the dysplastic lesions had totally undergone remission after the 3 months. The significant risk factors associated with cervical dysplasia were women aged between 26 to 35 years, adjusted odds ratio of 2.7, women with early coitus at 16 years, women with more than 3 children, and then age of first birth being 18 years. This is a picture of a dysplastic cervix with acetowhite lesions, and this is a normal cervix. Based on our findings, we concluded that considerable proportion of women living with HIV have cervical dysplasia. Significant risk factors being a young woman with early coitus at age 16 to 20 years, multiparity, early age of coitus, age of first birth. Cervical dysplasia risks among women living with HIV is similar, and then among the general population underscores the need for comprehensive reproductive care for women living with HIV. Cervical cancer screening is therefore paramount as part of the HIV care in HIV management. We therefore recommended to stakeholders that they should implement protocol on regular cervical cancer screening in all ART centers. By way of public health actions, we educated the clients at the ART center on cervical dysplasia, the causative agents, the risk factors, and then the prevention strategies. We also communicated our findings with the key stakeholders to update their knowledge on cervical dysplasia among the target population. We couldn't have done our work and with these people, so I would like to acknowledge them. Thank you.
Thank you so much for a very nice presentation. While we get folks on at the microphone very quickly, some countries, first, visually inspecting a cervix is not an easy feat, and it is indeed at the crux of this activity. There has been some debate about the use of acetic acid by direct visualization as the only mechanism to identify dysplasia versus pap smears. And we understand that pap smears require greater resources. Can you talk a little bit about what type of refreshment you did for the providers so that you might be assured to have more accurate and consistent identification of those lesions with visualization and acetic acid?
Thank you very much for the question. We sensitize the client at the HIV ART clinic by showing them the importance of getting early screening and detection so that they can be treated. And also, we gave them soft drinks, that is, we call them minerals, that's soda, and some cookies, which is actually a delicacy for clients in such deprived communities. And so there was high participation rate among the clinic attendants.
What about for the clinicians?
For the clinicians, they did not need much convincing because they were already aware of the situation. But we added them anyway to the refreshment.
The question, I think, was more in terms of how did you refresh the skills of the clinicians to identify lesions?
Okay, we chose midwives who were already doing the VIA, and then we also continued training them to help them sharpen their skills. Yes. Next question, please.
I have two quick questions, if I may ask. The first one is, did you offer some further treatment for the women you found to have dysplasia?
Yes,
biopsy
sir.
And,
Yes, we did cryotherapy with oxygen, and then we referred them for 3 months clinical reassessment and possible rescreening. But then all the lesions had undergone remission after the 3 months.
yeah, and good. And secondly, is Gambia thinking about HPV immunization program as a possibility, considering the high risk?
In the near future, it's very possible because that is key in primary prevention of cervical dysplasia.
Hello, thank you for your presentation. My name is Trisha Pennycook. I was wondering if there is a difference between the risk factors of women that have HIV and the ones who don't in cervical dysplasia.
The risk factors are similar, but in those with HIV, they progress to the cervical dysplasia stage and cervical cancer faster because of their lower immune levels.
Okay, thank you.
I'll ask one final question, which is that you started to mention about differences of women who, all of these women were HIV positive, but then you did an analysis looking at the women who had CD4 counts less than 200, suggesting these are women who had more advanced HIV disease. Can you expand a little bit about that? Did you see more frequent lesions in them or not compared to the ones who were not as advanced in their HIV disease?
Yes, please. In this study, CD4 count less than 200, the odds of getting cervical dysplasia was higher, but it was not significant. The p-value was higher than the 0.05 that we set.
Thank you so much. Our next presenter is on cost-effectiveness analysis of SMS and home visit reminders in reducing missed childhood immunizations in clinic appointments in River State, Nigeria, 2017. I will not start the count until you're ready with your presentation up here.
Good evening, everyone. Presenting cost-effectiveness analysis of SMS and home visit reminders in reducing missed immunization clinic appointments, River State. Globally, about 27 million children do not receive timely vaccination, which is a recommendation of WHO. This is usually due to high dropout rates from caregivers' forgetfulness. In some facilities in River State, they recorded as high as 36%. And an effective reminder strategy has been recommended. A cost-effective reminder strategy is important to reduce missed immunization appointments. We determine the cost effectiveness of SMS and home visit reminders in reducing missed immunization clinic appointments. The study area was primary healthcare facilities in River State. We conducted a quasi-experimental parallel 3-arm study. Caregivers that brought their babies for BCG immunization were recruited, and they had to own a mobile phone. The sample size was 300. We randomized the primary health care facilities into 3 groups. A group received reminders via SMS, a group received home visits, and the last group received no intervention. We sent reminders to these groups a week prior to schedule and a day prior to schedule. We followed them up according to the time of vaccination. When did they receive the first penta, second, and the third? We defined incremental cost effectiveness ratio as the additional cost gained per outcome averted. We define missed immunization clinic appointment as failure to keep scheduled appointments within 2 weeks of the due dates. We collected data using a questionnaire, immunization register, and pro forma to determine cost elements. We determined frequencies, proportions, and risk ratios. We calculated incremental cost effectiveness ratio. We determined the proportion of missed appointments averted, and we did a pairwise comparison of all the possible groups. Majority of the babies were male, and they were of the second birth order. Most of the caregivers in all the groups had secondary education. When we did the proportion of clients that missed immunization, home visit had the highest return rates. Only 13% of the people in the home visit group missed their immunization appointment. From the pairwise comparison, those that received SMS and home visit were at least 20 times less likely to miss their immunization appointment compared to those that did not. When we compared across SMS and home visit group, there was no difference in return rates among both groups. We went further to do the incremental cost effectiveness ratio, and it shows that SMS, the cost of averting missed appointment was 5.6 naira compared to home visit group that was 63,000 naira, which is equivalent to $15 and $175. So the interpretation of this is that the cost of home visit is 11 times more than SMS. For every missed appointment averted, SMS only costs 56 naira compared to home visit that costs 63,000. In conclusion, SMS and home visit reminders were equally effective in reducing missed immunization clinic appointments. However, SMS was more cost effective. We recommended that SMS should be used routinely in immunization services. So we're working with the primary healthcare director presently to see how we can scale up using SMS in the facilities. We acknowledge Nigerian FETP and ABU Zaria. Thank you for listening.
This paper is open for questions, and the first one will be, it was very smart to go ahead and put in the eligibility criteria owning a mobile home for all 3 groups. I'm wondering if you would talk a little bit about what is the general coverage of mobile phones, and I'm not talking about geographic, but rather if this intervention is to be scaled up to the population in general, it would depend on most of the population having a mobile phone. Do you know that information? What % of the general population of Nigeria owns a mobile phone?
From the study or from?
In general, because I think the recommendation would be to routinely use SMS to remind for immunizations, but ownership of a mobile phone may not be widespread unless you tell us otherwise.
Okay, yes, about 3 billion people own a mobile phone, and the distribution of mobile phone depends on the geographic region. For the urban regions, most people in the urban region own the mobile phone as compared to the rural area. So if we're dealing with the urban region, majority of the people there own the mobile phone.
Question?
Hi, I have a methodological question. Do I understand right that your randomization, did you randomize at the individual level or at the health center level?
At the health facility level.
So you randomized facilities to one arm or the other, but your analysis was at an individual level, is that
At
correct?
the facility level.
Your analysis was also at the facility level. So like at a facility, what proportion of children had missed visits? Is that right?
Yes.
Okay, first I misunderstood that. So then that clarifies that question. If I could then, a question for you about the cost of the mobile phone. I imagine a lot of the cost of the SMS was talk time. Is that right? The cost associated with the SMS arm was related to the talk time for the time for the sending the text messages.
Yeah.
Right? Do you think that the mobile phone service providers would be open to providing free text messaging for public health interventions like this?
Okay. Thank you very much. When we did the study, it was us that did it, but when discussing with the director of the public and primary health care, and they've said that they were also going to go into discussions with providers to see how they can make it free as a health promotion intervention.
Is there a cost associated with receiving an SMS? That practice varies.
Sending an SMS.
There is no cost for receiving one.
Yes.
Okay. One question here?
Thank you. In terms of your recommendation that SMSs should be routinely used, how do you ensure that the numbers that you have for each patient are maintained? And will healthcare workers have to build that activity into their routine data collection system to ensure that the numbers are always up to date and relevant?
Okay, so what we actually tried to do was to ensure that we took phone numbers at each study. We can't completely ensure it but at each visit, we took another phone number to ensure that the person was still using the same phone number.
Thank you so much. Very innovative, very interesting. Thank you.
Our next presenter is on outbreak of culture-confirmed Candida auris bloodstream infection in a neonatal unit of a public sector hospital, South Africa, July through September 2017.
Candida auris is an emerging multi-drug resistant fungus causing invasive diseases and hospital-associated outbreaks. On the 14th of September 2017, the National Institute of Communicable Diseases became aware of 4 cases of candidemia caused by Candida auris through the candidemia surveillance system at a neonatal unit at a public sector hospital. Initially, these 4 isolates were misidentified by the hospital's laboratory as Candida hemolone. Subsequently, these isolates were confirmed to be Candida auris, and an outbreak investigation was initiated. We conducted 3 studies in this outbreak investigation. First, we conducted a cross-sectional study to determine the magnitude of the outbreak, where we regularly reviewed the candidemia surveillance database to actively find cases. We went on to conduct a medical record review using a standardized case investigation form to collect clinical and laboratory data. Second, we conducted colonization surveys among admitted infants to determine the colonization prevalence at 2 time points. The first survey we conducted prior implementation of infection prevention and control measures of isolation or cohorting of infants colonized or infected with Candida auris, recommending amphotericin B to treat candidemia and the use of chlorine-based disinfectant for environmental cleaning. Third, or subsequently, we conducted a second colonization survey. We conducted an infection prevention and control observational audit among the neonatal personnel to determine their infection prevention and control practices. The cross-sectional study identified 2 additional infants, bringing the total of infants with Candida auris candidemia to 6, 5 of whom were female infants. The infant's median birth weight was 1,205 grams, with a median age of 23 days at Candida auris candidemia diagnosis. 5 of the infants were HIV exposed. Prior diagnosis, all of these infants received empirical antibiotic treatment and blood transfusion, and 5 of the infants received fluconazole and total parenteral nutrition. 1 infant died before candidemia was confirmed. 5 of the infants received amphotericin B to treat candidemia. 1 infant died after receiving treatment. The colonization survey, the first colonization survey depicted a colonization prevalence of 32% among infants admitted in all sections of the unit. This suggested a person-to-person transmission. Following a second colonization survey, the colonization prevalence was 3.8%. The infection prevention and control observational audit highlighted that less than 10% of the neonatal personnel adhere to infection prevention and control measures. We found a high proportion of admitted infants that were colonized with Candida auris. The cross-sectional survey and the infection prevention and control observational audit findings suggested a person-to-person transmission and a possible environmental contamination. Strict adherence to infection prevention and control measures likely contributed the most to preventing further cases. We recommended that the practitioners maintained a high index of suspicion for Candida auris and that invasive infections be treated with amphotericin B. Infants with candidemia or colonized with Candida auris should be isolated or cohorted, and a sustained adherence to infection prevention and control measures, especially hand hygiene, should be maintained. I'd like to thank the following institutions.
Thank you. Very, very interesting. And Candida auris is one of these organisms that is difficult to get rid of. It's impressive that you were able to reduce colonization rates from 32% to 4%. The idea would be to get it down to 0. Can you talk a little bit about what are the infection prevention and control measures that have been reinforced going forward?
Going forward, the infection prevention control practitioners of the unit are now have intensified the in-service trainings where they do an observational audit and they do remedials and they continually in-service the practitioners. And amongst this includes the mothers in the unit, this includes everybody that works there. And the high suspicion index of the Candida auris is still to be maintained even going forward, because if colonization was detected, we don't know for a fact if we managed to eradicate.
Congratulations on a really nice investigation and a very clear presentation. Thanks. I'm interested in the individual level risk factors. You mentioned that 5 out of the 6 infants were girls and that the median birth weight was about 1,200 grams.
Yes,
so I wonder if you have any ideas about why so many of the cases were girls, and is 1,200 grams considered low birth weight in South Africa, and if so, do you think that's telling you anything about the risk factors at the individual level?
Okay, thank you for the question, sir. So regarding the female and male ratios, we're really not sure about it. However, this is in a neonatal unit and among infants born prematurely. So this is one of the risk factors.
Sorry, I missed that very important point. Thank you.
So yes, it is one of the risk factors. Okay. Yes, sir.
Any other questions?
By HIV exposed, do you mean HIV positive? Like the
Oh,
babies?
HIV exposed means that they were born from mothers that were HIV positive, though they tested HIV negative, the exposure.
Thank you so much.
Any other question? Thank you very much.
Our next presenter will be talking about transmission of Neisseria meningitidis in a military training unit, Vietnam, August 2017.
Good evening. I would like to thank the organizers for giving me the opportunity to present our investigation. As you know, Neisseria meningitidis is a major vaccine-preventable cause of meningitis, septicemia, and pneumonia. At least 13 subgroups have been identified, but 6 subgroups are responsible for more than 90% of meningococcal cases worldwide. 10 to 15% of cases are fatal, and bacterial are transmitted via large respiratory droplets. Among military trainees, the asymptomatic oropharyngeal carriers rate is about 15%, and meningococcal disease can reduce troop readiness. Company belongs military unit Y consists of 8 officers and 136 trainees. Troops live in small barracks with bunk beds. On 18th of August 2017, A member of Unit Y was diagnosed with meningococcal meningitis. He was treated and survived. To prevent additional cases of disease, a rapid response team was formed and deployed. We searched for additional cases by using case definition and looking at medical records. A suspected case was defined any disorder of Unit Y with sudden onset of fever, headache, and or meningitis presented during 15th of August to 15th of September. A laboratory confirmed case was defined as detection of Neisseria meningitis in cerebrospinal fluid by culture or polymerase chain reaction. We used standard questionnaire to interview the investigator and all 36 close contacts. We also collected throat swab sample for PCR testing from the same 36 close contacts. In this case, a 19-year-old male was diagnosed with meningococcal meningitis caused by subgroup B. 5 and 6 days after the index case, 2 additional trainees were diagnosed with acute pharyngitis caused by Neisseria meningitis group B. Fortunately, they were treated successfully and recovered quickly. As I mentioned, we identified 36 close contacts of the index case. This table shows results of our carrier survey. Among 36 close contacts, most of them were trainees, 1/3 were current smokers. All provided throat swab sample for laboratory testing. 24 or 67% were positive for meningococcus, and all 24 were subgroup B, and none of them had received meningococcal vaccine before. After the detection of the index case, we implemented azithromycin prophylaxis for all 144 members of Unit Y, accompanying Company Z, and we also enhanced other countermeasures, and no additional cases were reported. Our investigation has certain limitations. Importantly, we were not able to repeat the colonization survey after the administration of prophylaxis. Therefore, we could not estimate the effectiveness of prophylaxis against colonization. We also were unclear about which of our interventions prevented additional cases of disease. We conclude that Neisseria meningitis, subgroup B, caused meningitis and pharyngitis among the populations of military trainees in Vietnam. The high prevalence of pharyngeal colonization suggests widespread transmission, and additional cases of meningococcal disease were likely prevented through multiple interventions. We have some recommendations as follows. First, soldiers should be educated about signs and symptoms of meningitis and should be encouraged to seek help promptly. Second, vaccination with meningococcal vaccine should be considered as one strategy to maintain troop readiness in Vietnam. And finally, future colonization studies should be used to estimate the effectiveness of meningococcal vaccines in military training units. I would like to acknowledge the following individuals and organizations. Thank you so much for your attention.
Thank you so much for the very nice presentation. Quick, interesting question. 36 of the 144 persons in the barracks were considered close enough contacts to do nasopharyngeal swab, yet all 144 received prophylactic azithromycin. Would you clarify what the difference is between one and the other? And maybe share with us a little more about what the crowding conditions were that would have led to this classification?
Yeah, thank you so much for your question. As I mentioned, we identified 36 close contacts of the index case. Those are trainees who live the same barracks or participate in the same training activities with the index case. However, we have followed the regulations of military medical department. We have the prophylaxis using azithromycin for all the people who are the same unit with the index case.
A follow-up question, slightly related, is about the recommendation of using meningococcal vaccine. As you know, there are different types of meningococcal vaccine, and it's important that you all found Neisseria meningitidis serogroup B, because only one certain type of vaccine will cover serogroup B, the other one won't. Based on that, and it's which one of the vaccines do you think would be most appropriate for immunization of this group in Vietnam?
I think that your question is very interesting, and it's not easy to answer. As I understand, there are 3 types of meningococcal vaccines: polysaccharides, conjugate, and outer membrane for serogroup B. And as you know, conjugate vaccines are proven to be effective for both colonization and for invasive disease. So we prefer conjugate vaccine. And quadrivalent vaccine contain 4 antigens of meningitis. However, it doesn't include serogroup B, and it's very difficult to develop vaccine against serogroup B. So I think that will be consideration for our leaders and taking it into account for the futures to maintain our troop readiness.
Thank you. This is a common scenario, meningococcal outbreaks or meningococcal disease in shared living facilities, whether it's prisons or military or boarding school. So I want to congratulate you for taking the time to do a thorough investigation, because I think it's important in doing the carriage study also to dig a little bit deeper into understanding the dynamics, and then doing these investigations raise the attention and get some visibility for the work to make policymakers pay attention to possible interventions. So in that light, how realistic do you think it is to get a vaccine recommendation or have vaccine for military recruits in settings like this? Or do you think more data are needed, more investigations like this to highlight the problem?
Thank you so much for your question. I think we need to implement more investigation, both in epidemic setting and the normal condition setting, to find the prevalence of which serogroups of meningococcal meningitis is prevalent. And based on those results, we can choose what type of vaccines should be most appropriate for use in the military. Thank you.
Thank you. Very nicely done. Our next presenter is about adding methanol to rice whiskey is a risky practice, as shown by an outbreak investigation in a rural commune in central Cambodia, 2016.
Okay, good evening, everyone. I'm from Cambodia. My name is Sosodaro. I'm here to present with about methanol poisoning outbreak in Cambodia 2016. Methanol is a colorless toxic alcohol, and on December 8, 2016, there was a report to Cambodia Communicable Disease Department from the Kampong Chnang Provincial Rapid Response Team, which there was 41 hospitalized cases, and they are suffer from vomiting, nausea, respiratory distress, blurred vision, and headache. And also there was 10 deaths in the commune. And the CCDC conduct a reassessment, conclude with the level of high risk, and which need to be investigated to identify the magnitude of the problem and to find the source of the outbreak and to provide recommendation. This is the location of the outbreak. And this picture shows about the hospitalized case. We collect information from hospitalized case and also review the medical records. We also conduct a case control study in the commune, and the case we random from the patient dead or alive who was living in the commune from November 1st until December 10. And for the control, we select from the neighbor of the case. We also collect feral vines from little swab and send to the lab to do the methanol testing. We calculate data using APN4. As a result, we identify 42 suspected cases, include with 18 female, with the median age of 35, rank from 20 to 78 years old. And this is the epic curve of the outbreaks. And we got notified on 8 and we investigate on 9. We identified 15 deaths, and all of them were the heavy drinkers. This is the characteristics of the case and control. We see that most of them, about 61%, is the male, and most of them are farmer, and also they are mostly from the Ampal village. Those 4 villages are within the Kadol commune. As a result from the case control study, we point out that consuming rye wines and consuming rye wine more than 4 times a week, it is a heavy drinker, significant. And 3 out of 12 rye wine sample was present with the methanol concentration of 1.7, 1.4, and 0.2%. This is the picture of the rice wine cell in the commune. And the allowance level for the methanol in rice wine in Cambodia is 0.15%. So as a result for those 3 samples was about 10 times higher. And rye wine was produced by rye fermenting until it became a liquid, it mildly alcohol. But because of the seller or the producer want to increase the benefit, so they add the water into the pure rye wine, and then they add the methanol to make it stronger and flavorful. And this is the picture of how the people sell rye wines in the commune. In conclusion, contaminated rye wine was associated with this outbreak, and adding methanol is the risky practice. And local rye wines was destroyed by local authority. And recommend that we have education to rye wine seller and producer must maybe reduce this practice. And food safety law and regulation need to be strengthened for the enforcement. And I would like to say thanks for this person. Thank you.
Thank you so much. I imagine that drinking rice wine is not a new practice. Probably adding substances to the rice wine is also not a new practice. And being so cheap, methanol is an attractive additive, for lack of a better word. Why do you think that this particular cluster of cases happened? What was different about it than all of the other times that methanol or other additives have been included in rice wine?
Okay. Actually, in Cambodia, rice wine is produced as a homemade. It is the local product. So people in the commune, the user, they sell the rice wine in the commune and distribute to all retailer shop. And they add the methanol is the practice of them. So, but they didn't have any measurement. Actually, they don't know how many methanol they need to add into the rice wine. So maybe one day or another day that rice wine may be add into the rice, methanol add into rice wine, so maybe it become the outbreak.
It may be relevant to say that methanol should not be consumed in any strength, so there isn't a safe dose.
Yeah.
And that may be a message that's important, as opposed to suggesting that certain levels are appropriate.
Yeah.
My name is Sahid Gidado from the Nigeria FETP. Very good presentation. I'm just wondering, were there additional cases after your investigation? Because the epic cough really indicated that after your investigation, there were no additional cases. The second question I have, did you institute any public health measure to really curtail this outbreak? If you did, please kindly share those with us. Thank you.
Okay, a little bit epical here. We do investigate it a little bit late already, but at the time of the notified death, the rice wine, because before we have the experience related with the methanol poisoning in Cambodia. So when we got the information from Kampong Chhnam province, and we already notified to the local authority to temporarily stop the rice wine selling in the commune already. And that's why when we go investigate more, and we still point out that the rice wine were contaminated with the methanol, and also we recommend to the local authority and also the other relevant organization to raise the awareness of the methanol and the practice of adding methanol into rice wine to the seller and the producers.
Thank you. Very nice presentation. Congratulations. Looking your table where you are talking about risk factors, I saw that exposure to other exposure okay. Could you consider that like a risk factors?
Okay, please.
Yeah, I want to understand if you can explain exposed to other exposure, it is a risk factors. Can you explain?
Yes, because here I want, at the time we investigate, we also consider some risk factor that is most commonly become poisoning, food poisoning, like cassava, dead animal, and sometimes the thought, the kind of rock that is toxic also. So that's why we include it in the other exposure here.
How can you explain exposed to pesticide is a protector factors, not, how can you explain that? Exposed to pesticide is a protector factors.
Exposed to pesticide here is not significant. We see the 95% CI here, it's 0.0 until 64. Even though the OR here is protective.
Okay, thank you.
Yeah, yeah.
Thank you so much. Sorry, Jerry, that was the last question. Thank you, very nicely done. Our next presenter is speaking about prevalence and determinants of delay in seeking medical care among newly diagnosed pulmonary tuberculosis patients, Kyrgyzstan 2016. You'll notice I am abstaining from pronouncing your name, so I will not commit a huge mistake. I apologize, but trust me, you probably don't want me to try to pronounce it. Go ahead.
This one. Good afternoon. Tuberculosis is a health problem in Bishkek city, the capital of Kyrgyzstan. During 2014-2015, the annual notification rate 118 per 100,000 was higher than the country rate 98 per 100,000. More than 1,200 new pulmonary TB patients were identified in the city. 162 of them had advanced disease stage, a possible indication of delay in treatment initiation. Delay in attending for care can lead to advanced destructive disease forms, negatively affects treatment outcomes, further disease transmission, especially in the case of symptomatic pulmonary TB. In 2016, we conducted a cross-sectional survey in the city. The objectives were to assess the level of delay in attending for medical care and determine risk factors for delay among pulmonary TB patients. The study aim is to provide appropriate recommendations to improve timeliness of disease detection. In the study, we surveyed all new symptomatic pulmonary TB patients, aged 18 years or more, and were identified in the city TB registry during 2014-2015. We enrolled 529 patients. TB patients who were identified through screening programs were not studied. We defined a case of delay if the time lag between disease onset and attending for care was 30 days or more. We collect information for care. we collect information on disease manifestations, date of symptoms onset and attending for care, and on other possible delay-associated factors. This slide shows general description of the study group. 63% were unemployed. 58% did not have good knowledge about TB. 50% had only school education, and 70% were singles and lived alone. As to prevalence of delay, 35% of all patients delayed in attending for care. In subgroup analysis, the prevalence of delay was highest among people who live alone, 50%, those with other chronic disease, 42%, those who lack awareness about TB, 38%. In monovariable analysis, living alone, history of other chronic diseases, employment status, and TB awareness had a p-value less than 0.1 and were included in multivariable analysis. In multivariable analysis, independent risk factors for delay were living alone, observation 2.2, history of chronic diseases, observation 1.5, good awareness and knowledge about TB was protective against delay, observation 0.6. In conclusion, the prevalence of delay seems to be unacceptably high in Bishkek. Patients who live alone are more likely to delay, probably because of lack of family support, while those who have chronic diseases were probably delaying because they were attributing symptoms of poor health to those conditions. As good prevalence and knowledge about TB seem to be protective, we recommend that through well-designed and properly targeted educational messages, people should be informed about the tuberculosis manifestations and the need for a timely attendance for care. Thank you.
Thank you so much. There's two aspects of this that are very interesting. We tend to think of tuberculosis as a disease that's transmitted to close contacts. And the fact that living alone was a risk factor for not seeking care demonstrates this looking at the problem from a different angle. Can you elaborate a little bit on, for the folks who were living alone, how would they have acquired the disease?
Спасибо за вопрос. Близкий контакт может быть не только семейный. Мы считаем, что контакт может быть и в других обстоятельствах, это в рабочем или в других местах.
So the question was on the variable that was significant living alone. It's really close contacts, but TB can be acquired not only through the it's various different contracts like exposure on neighbors or in just community-based or hospital-based, whatever it is. There were different opportunities to acquire.
So living alone did not imply not having close contacts with someone who had active TB.
Sure, yeah. То есть жить один, это не означало то, что они живут одни, вернее то, что близких контактов с туберкулезом не было.
Okay. A nice presentation. Did you look at the socio-economical status of related to late health seeking for TB treatment and also the distance from where they live to the health facility where they will get services for TB?
Хорошее исследование. Вы посмотрели на два фактора. Социально-экономические факторы для того, чтобы вообще обращаться за помощью для лечения туберкулеза. У вас бесплатно или нет? А второе, на расстояние от, как далеко стационары находятся. Это учитывалось, на задержку влияло, как далеко они живут от медицинских учреждений?
Спасибо за вопрос. Мы изучали очень много различных факторов, но, к сожалению, они вышли незначимыми. Да, мы изучали.
Расстояние смотрели?
Нет. Yes, да, мы изучали факторы.
Thank you for the question. Yes, we were looking at these variables, but they were not significant in the study and were not presented.
Thank you.
Yeah. The treatment in Kyrgyzstan is free, so it's not really the problem to get the treatment.
Okay, thank you. Good presentation. My question is similar to the last colleague here. Just wanted to find out whether you examined the role of social stigma in delay and also the use of maybe local medications or local beliefs, traditional beliefs that could also potentially be responsible for delay in seeking care.
Аналогичные вопросы. Вы смотрели на такие факторы, как социальную стигму? Влияло ли это на то, что они не обращались за помощью? И второе, если люди просто занимались местным лечением, какие домашние способы лечения, знахарки, такие вещи. Вы рассматривали такие перемены?
Да, спасибо за вопрос. Мы рассматривали такие перемены именно в отношении как бы традиционной медицины. У нас было случай использования кобыльего молока в качестве лечения. Но, к сожалению, они вышли незначимыми.
Thank you for the questions. We were looking at these variables. For traditional medicines, people are using horse milk for treatment, and it's like initial treatment before the applying for healthcare.
Okay. Could that be responsible for delaying among some of these patients?
We studied this variable. It was not significant.
Okay,
Yeah.
okay. Thank you.
For the last question, would you address the role of HIV co-infection? And this would be the last question.
ВИЧ-инфекция. Здесь есть какая-то связь с ВИЧ-инфекцией? Смотрели, среди пациентов была ВИЧ-инфекция или нет?
Да, смотрели, но...
Влияние на задержку есть? Сколько у вас ВИЧ-инфекций?
Мы рассматривали вопросы, то есть связанные с другими заболеваниями, именно такими заболеваниями, как хроническими, но среди них мы не выявили как бы...
Ни одного не было случая?
Да.
ВИЧ-инфекции?
Да.
So we were looking on comorbidities, but in this study population, there was no one HIV patient.
Wonderful. Thank you so much.
Thank you.
And thank you for translating. Our last presenter of the evening, influenza vaccine effectiveness in Australia.
Yes, all good. Thank you. Okay, I'm presenting on influenza vaccine effectiveness for the last 6 influenza seasons in Australia. I'm sure most of you know what vaccine effectiveness is, so I'll be brief. It's a measure of the performance of a vaccine in reducing disease in a population under real-life circumstances. And by that I mean that it includes the ill and the elderly. It's an important public health tool because it could be estimated mid-season, which, for example, if it shows to be low for a particular season, it alerts public health authorities that alternative measures need to be implemented. I'll give you a bit of background of the surveillance system in Australia for influenza-like illness, or ILI. It's called ASPREN. It's the Australian Sentinel Practices Research Network, and it conducts ILI surveillance system. And the data that emanates from ASPREN is what we use to estimate vaccine effectiveness. In this map, you can see the location of the GPs that participate in the system, and there are approximately 200. So how do we estimate vaccine effectiveness? We use a method called the test negative design, and we also estimated it at 2 time points, during and at the end of the season. The test negative design is represented in this figure, and it's a variant of a case control study. So what we have here in the first panel is a representation of people that present to a participating GP with ILI. Some would be vaccinated, and these are the red figures. Some would be unvaccinated. So at the discretion of the GP, a subset of this group is identified for swabbing. So nasopharyngeal swabs are collected from this subset of people and tested for influenza A and B. Then the odds of vaccinated positives is compared to the negatives, and by logistic regression, and based on this you calculate V as per the formula shown. Okay, so let's move on to results. These are overall vaccine effectiveness estimates for the 6 seasons, 2012 to 2017, and I'm showing both the interim and the final. So the interim was estimated mid-season, the final at the end of the season. There's a lot of information here, but for most years, the effectiveness is around 50%, but what I really want to show you with this figure is that the confidence intervals are smaller when your sample size is larger, and that's more visible for 2017. This is a summary measure, and this is not necessarily very informative, so what public health authorities are more interested in is to unpack that estimate and have a look at, for example, the estimate specific for influenza A, H3, and 2 by age group. And I'm only showing data for 2017 for the sake of brevity. But the pattern we identified here applies to the other years too. So here it pretty much stands out that the confidence interval for both pairs, interim and final, are very large for children and the elderly. And also the concordance between these estimates is low for those two groups, and I'll show you why that is. So this figure shows the proportion of participants in the ILI surveillance system in Australia by age. And you can see that children and the elderly are underrepresented. So approximately 60% of participants are adults, and on average 20% of participants are elderly or children. And in some years, like 2014, the percentage of or proportion of children is much lower. So what's the public health significance of this study? Our findings indicate that to improve the reliability and usefulness of influenza vaccine effectiveness for public health action, the ILI surveillance system in Australia needs to be expanded, and we advocate for a larger number of specimens to be collected, particularly from children and the elderly, from people that present to participating ILI sentinel GPs. And expanding the routine ILI surveillance system in Australia will allow more precise VE estimates overall, but by subtype and lineage, and importantly for vulnerable groups like children, elderly, those with underlying medical conditions, and Indigenous Australians. I would like to thank TEPHINET for the sponsorship that allowed me to be here tonight. Thank you.
So the test negative design has become very important in calculation of vaccine effectiveness of influenza. Would you talk a little bit about the limitations of this test negative design as compared to the traditional methods of calculating vaccine effectiveness?
I would say that any estimate you calculate would be as good as the quality of your data. So if we look at the case definition for ILI in Australia is fever, cough, and fatigue. And one of the things I can think of is that the way they record fever is by self-reporting. So that could introduce some biases. My understanding is that when we compare the test negative design with other methods, confounders are sort of like the chance of confounding is much less compared to other methods, from my understanding. Yes. Like there's a number of publications that actually point out that this design being the best we could do at this stage.
A few years ago, there was an issue with the safety of one of the Australian produced influenza vaccine in children. Are you able to look at effectiveness by manufacturer, in the future perhaps?
That's a very good point, and I believe that we should be doing that. But let me just bring up this image. Just so that you know, the numbers here at the top of each column are the total number of specimens that were actually collected each year and from which we are drawing our calculations for VE, and they are way too low to actually dig in at that level and be able to unpack it by, at that level. So the confidence interval, if we do something like that, would be massive and it would be totally uninformative. So we need to first expand our surveillance system. And the other point, that's even more important, is that GPs, we are already asking them to collect a number of measures for the ILI database, and currently they are not collecting that information. So yeah, that should be a recommendation to them so that we can provide the VE5 manufacturer. Thank you.
Okay, Jerry, go ahead.
It's kind of a dumb question. Basically, this is a case control design for submethylene vaccine efficacy. It's very well known, been done for years, and with adequate sample size, you can get good data. So could you explain a little more, just for us uneducated, what do you see as the problems with the quality of data you got, or with your estimates?
The main problem for me is that GPs, for some obscure reason, unfortunately we didn't do a qualitative research study to find out why, but they are obviously not collecting specimens or enrolling even ILI patients that are children or adults. So for the data I have, that's the main problem, I would say. Yeah.
The vaccine effectiveness also relies heavily on the concordance of the strains that are represented in the vaccine with the circulating strains for that year. Do you have data about that?
I didn't want to show this because I felt like I didn't have enough time, but this is showing the number of ILI consultations. I'm not sure if it's very easy to see, but we have here H1, H3, and B. So for example, for 2017, which is the VE estimates I showed, we had a predominantly a H3 subtype, and also it was really also B. So B and H3 were both co-circulating. And you're absolutely right. Like the vaccine is going to be good if it's a good match for what's circulating that year. Yeah, there are other factors that affect it too, but
you might want to
yes.
consider including something that would reflect that match or mismatch as you present the data by year in another one of your tables. Yes, about there.
Yeah.
Yeah. Okay.
Yeah.
Thank you so much. Thanks to you.
Thank you.
I would like to acknowledge all of the speakers because they've done a stellar job both at staying on time and being able to respond to questions. I think that speaks very highly both of their work and of the support that they received from their mentors and trainees. So a round of applause for all of them. The other group is also on time, so they are going to be walking over briefly. Kindly stay here because the final words will be from this room, so please stay here. There will be certificates of participation distributed for everyone who presented, and again, wonderful, wonderful job. Thanks to everybody who has contributed. Kip, did you have any final words as folks come in?
Just a logistical thing, really just echoing what you said. I think I'm told that the other room is just a few minutes behind us, and then we'll all reconvene here to give out the certificates. So thanks for your patience for just a couple of minutes. Thanks.
Question. I realized that I turned back. Jerry, where's Jerry? Who had some really burning questions, and I said, last question. So Jerry, I'm going to put you on the spot. I'm putting you on the spot, Jerry. If you had a question,
about one of the presentations? So this is going to take a couple of minutes? No? Okay. Excellent. All right. So folks are coming back. I will not sing and dance. You don't want to hear me sing and dance. Bob?
We'll wait a minute or two to get everybody from the room to filter in. I'm just going to be really quick because I know everybody wants to. Can you announce the names? I don't know who has the name list. Yeah. Okay. Okay. I think that would be use the certificates. That's the best I can think of.
Would you mind saying them and then DEC and I can hand them out as opposed to us fumbling through?
Yeah. Okay. Yeah. If I can get the list. Everybody, you don't have to stand in back. You can get comfortable. There's plenty of seats up here. I guess they all want to stand.
So the certificates are in this order, so
Okay.
you can just use that.
So I just want to reiterate what Raina said a minute ago. She took the words out of my mouth. Everything was spot on time, which is really makes a conference run well and be well appreciated. For any of you who have been into sessions that drag on an hour after they should finish. So this was very tightly organized. Thanks very much to the staff of TEPHINET for getting this all set up and working behind the scenes. Everything has come off without a hitch. Also wanted to say that there were 241 abstracts that qualified for this conference, being from current residents, or at least residents who graduated in the past year and did their work during their program. And we could only select, let's see, 6 plus 20, so 26 out of those for the posters and the orals. So unfortunately, there are a lot of awfully good studies that we couldn't show here. And I hope that those will be shown later at one of the NET conferences, AFINET. We just had the EMPHANET conference 2 weeks ago, so we saw many of them there. And I hope that many of you can go see the other really good presentations at those. And I also appreciate seeing a wide variety of public health topics covered in this very, very brief oral poster presentation. So thanks very much to everybody, for all of you who showed up to ask questions and to support your colleagues from the FETPs. We have a team of judges, a small team, and they will be deliberating, and the prize for the poster, best poster presentation, will be given tomorrow. Okay, but right now, I'm going to move along quickly. I'd like to introduce Dr. Baggett. Oh, one last thing. One last thing. You can see the posters. If you didn't get to see them in the other room that you weren't in, you can see them in this center section here. There are 2 LCD screens set up, and they'll be there until tomorrow evening. So you can go through anybody's poster, any topic And it would be even better if you could round up the presenter to work with you on it, to explain it to you. But so the presenters may be asked to revisit their poster with some people who are greatly interested in them. So at this point, I'd like to ask Kip Baggett and Dionisio Herrera to come to the podium to deliver the certificates. I will announce the names, if I have the right sheet. It's this one. Okay. What's the first one? Okay. So let's see. We need to organize this a little better. Should have. Can we have all the presenters up in the front row, please? That way we don't have to call you in from the back of the room. We need room for 18 in the front row, so okay. Okay, that was very well organized. Thanks a lot. So, we'd like to start off with Frida Loy Aseng. Joseph Acheapong, I hope I got that right. Thank you. Anna Gemma. Uche Kachi. Utemeling Moema. Tan Dan Fan. Sotarko Soy. Sanjarbek Temerbakov. Jimena Tolosa. Saima Dill. Amabo Frank. Mfo Sikosana. Devendra Kumar. Mahmoud Riaz Riaz. Claudia Ruscher. Tanzin Dikid. Jekusi Cacho Tatiana. How close did I get? And Eunice Wachira.
Yes, to say thank you and congratulations to all of the poster presenters. Thank you to all of the tutor, coordinator, director of the programs, resident advisor, people that support this excellent presentation. And also I'd like to say thank you to all of the participants that are already here at this time in the day, in the night. You know, for the TEPHINET family, this is one of the most two important nights for every year as a part of the EIS Conference. And we are so happy to see that every year we are improved in the quality of the program, we are improved in the diversity of the participants, and also we are increased, and that is a challenge now, in the number of posts of the Astra we have received. For example, this year we have received 369 posters around the world for 49 countries. This is the highest number of Astra we have received in the history of the International Night. That is incredible. And you can imagine this 21 poster and the 6 oral presentation is just the excellence of this 369. Congratulations for everyone. Thank you very much.
Okay, thank you. As I look around the room here, when I came in tonight, I was very pleased and excited about the number of people that were here for International Night, the poster night. We always get a good turnout for the oral presentations, but it was great to see so many people here for the posters. And I think I'm now even more impressed to see the number of people that are still here till the bitter end. So thank you all for being here. And let me echo Dr. Dionisio's thanks to the organizers. Tonight it's a huge amount of work. A lot of people from TEPHINET and from CDC have done put in a lot of effort to make this go off without a hitch, and I think it's safe to say that it did. It was great. I also want to thank CDC Foundation for their help with the food. We did this right over dinner time, so it's really helpful to be able to have a little energy going into the presentations. Thanks to the moderators, Reina, Professor Chimanga did an excellent job, really kept us on time, and why you're all going to be leaving even earlier than what the schedule says here, so that's great. I want to acknowledge 3 people that are not in the room tonight because unfortunately they had visa problems, but these were 3 people who had poster presentations that would have been presented tonight if it weren't for that. There were 2 from Ethiopia, Balay Mamuya and Yashambel Warku, and then also a trainee from Iraq. I can't read your writing, Seymour. Is it Ali Jafar? So we're sorry to miss them. But this was a really great evening. I was floored by the breadth of the presentations, the breadth of the topics we started in the other room with the occupational hazards of semen collection in, I'm blanking on where that was now. Oh, it was in Pakistan, of course, in Pakistan. We had maternal child health. We had, of course, acute infectious disease outbreaks, HIV. We had a very nice cost-effectiveness analysis tonight. So there was really a range of topics. So my final thank you and congratulations goes to the presenters, of course, for the fine work, and to their mentors and supervisors who helped them get to this point. We all know how important that is. And I was really pleased with all the presentations that I was able to see, not only with the quality of the epidemiology in the presentation, but the emphasis on the public health actions and the follow-up to occur afterwards. So remind you all that tomorrow I hope to see all of these faces plus many more for the second international night. It promises to be just as good as tonight, and it will be very interesting. And also there will be food preceding that event as well. So we'll look forward to seeing you all there. I think before I give the final closeout, I think Amber, oh, okay. I'm going to turn it over to Amber for just a short logistical announcement related to tomorrow, I think. Thank you very much.